artificial intelligence. And he's going to be telling us today about deriving imaging-based biomarkers for non-small cell lung cancer patients using deep learning. Thank you.
Thanks. Thanks everyone for the opportunity to speak today. I'm excited to talk a little bit about the work that my lab has been doing for the past year that I've been on faculty here. Some of the work today derives from the research I did as a resident, and as well as the work that we've done for the last year, specifically in the area of deep learning and machine learning. Here are my relevant disclosures. So our group is a very, very unique interdisciplinary lab. We have clinicians, data scientists, computer scientists, mathematicians, and engineers that span pretty much the entire campus, including a large group of undergraduates, graduate students, as well as medical residents. Our interest is specifically in the application of machine learning to clinical oncology. And our major research areas are in the areas of machine learning algorithm development, improving the efficiency of machine learning techniques, and novel clinical applications of existing machine learning techniques and algorithms. And an area that we've been particularly interested in, which is sort of the most emerging area within machine learning, is deep learning. And so before I kind of go into the work that we've done with respect to non-small cell lung cancer, I'll kind of give a little bit of a framework for our discussion, because I think these words are oftentimes thrown around, and then very frequently they're kind of used as equivalent, but they're actually somewhat different. And so deep learning is really just a subset of machine learning. It's a method in which we can kind of, it's a method of machine learning. And I think that's often spoken about in the context of artificial intelligence. And the reason for that is because it's able to learn features with raw data. And so it's allowed to utilize information in an end-to-end format, which in many ways is very, very useful and can be kind of utilized when we're developing AI technologies. Deep learning is kind of the underpin, the engine for a lot of things that we're using today. So virtual assistants, self-driving cars, natural language processing, anything that pretty much is being used by Facebook or Amazon or anything like that is primarily used in the context. I mean, is primarily using deep learning in some way, shape, or form. And so our interest is particularly trying to apply deep learning in a clinical context. And one of the big areas in which deep learning is particularly useful is in the areas of image analysis. Before we go into sort of the project, I'll talk a little bit about what a deep learning algorithm is. And some of this might be a little bit basic, but I think it's always useful just because I'm not sure exactly how many people here have applied math background. So I think that a common way in which we apply deep learning technology is in the area of classification. And so when we look right here, this is just a simple classifier in which we have inputs, weights, and a prediction. So this can be a regression or any sort of technique. And when we're thinking about inputs, they could be pixel intensities, clinical variables, lab values, words in a sentence, numeric features. So any sort of input data that you want to put in. The weights are really parameters in which you optimize the function that is modeling your data. So they could be coefficients in your regression, or they could be, what we'll see here is the weights in the neural network. After the weights are optimized, they go through a function that can be, and I think that really is the special sauce and what determines what machine learning technique you're using. In deep learning, there's a specific type of function that's utilized, and I think that that's probably what makes it unique compared to a logistic regression. Afterwards, you look at a prediction, you get a class output. It gives you a probability of your classes. So for example, if we were developing a classification algorithm that was to take input data, let's say clinical variables, and determine whether or not that patient had cancer or not, we would develop a class probability. And we would have 90% cancer yes, and 10% cancer no. And from there, you can actually make a prediction depending on what you create as your cutoff. Now, when we're thinking about deep learning and specifically compared to regression techniques, in many ways, it takes the most important part of a classification and it sort of replicates that in a netted format. And so what we're doing is we're taking the most important part of that singular classification and we're kind of creating it in a nested format with multiple classifications, with multiple parameters that are able to model a very heterogeneous function, a very, very difficult function in a nonlinear space. And so this is a neural network. It's the fundamental deep learning, a fundamental unit of a deep learning algorithm. And it's, I guess stylistically, one can think of the layers as representing different levels of abstraction. So for example, if your input was an image classification problem, the input would be the pixels. The first layer might be representing, lines and edges that you see. The second layer might represent shapes that are drawn from those lines. The third layer might represent, facial features. And then the fourth layer would be a facial recognition algorithm. And so similarly, each layer can kind of represent a different level of higher levels of abstraction. And so neural networks, the one maybe disadvantage, or maybe one thing that's important to note, is they require, they're supervised learning algorithms, so they require a significant amount of training. And there's a training phase, which requires labeled data. So it's not an unsupervised algorithm, it's a supervised algorithm. And the weights are initially considered to be random. And it's very time intensive, and it requires high performance GPU servers, which we've been very fortunate to have here at Yale. We have 2 of them, 2 NVIDIA DGX-1s, which are basically top of the line. And so what happens is that as the input layer takes the function, the weights are randomized, and it promulgates through the hidden layers. And then you get to an output layer, and at that output, you generate a predicted output, right, using random weights. And that predicted output is just a vector of what your data represents based on your neural network architectures. There's a true label that we have, right, because this is labeled data that we're training, and so we have a true representation of that vector, and then we use an objective function to calculate the loss. So how much our true label is from what our predicted label is. And that tells us how off our network is, you know, in the most basic form. And then what we do is we adjust our parameters backwards. And so we go back and minimize that loss. And so what we can see here is that we go back and we adjust our weights. And so initially our loss is very high and our accuracy is very low. When we start training, our model is basically using random parameters, random coefficients, you know, if you will. But then as we kind of go to our second sample, we continue this process. And over time, we see that our loss function decreases and our accuracy increases. And so what we're actually trying to do is optimize. It's an optimization problem of that objective function. And so what we were doing is it's a minimization problem. And fundamentally over time, with more training data and iteratively over time, your loss decreases and your accuracy increases. And so your training is essentially complete when you minimize your loss to hopefully 0 or close to it. And then you keep the parameter weights from that moment. Perfect. Great. And so when we're thinking about neural networks, I think that the one that I've explained to you is just a feed-forward neural network, which is a simple way in which we kind of explain them to, you know, it's the most basic form of a neural network, but there's actually very, very complex architectures. They all still fundamentally rely on the same sorts of mathematics, but they are more so tailored for the data that they're using. So feed-forward networks are very much used for very you know, low-dimensional data that's already feature engineered. Convolutional networks are very, very common in image analysis. It's primarily what we use in the context of our lab. Recurrent neural networks are very useful for evaluating sequences because they have what they call memory, so it can understand sequences. And then residual networks are something more complicated, but they're very useful in introducing random error so the networks don't memorize your data set. And so these networks actually can become very, very complex with multiple neurons. But I think there's some benefits to this sort of algorithm compared to a standard regression. For one, you can predict multiple outputs simultaneously. And these outputs do not necessarily have to be related. Because we're looking at a nonlinear, we're trying to model a nonlinear function, or I guess it could be linear, but it doesn't have to be linear like a regression, like many forms of regression. We can look at different disparate outcomes that are related or unrelated. And also we can train them all simultaneously. So feasibly you can develop an algorithm, which I'll show you in a little bit, that predicts multiple outcomes at the same time. The other thing that I think is important to appreciate is also that these parameters, so those lines represent each parameters. And so if you think about a regression, when I was doing undergraduate work in applied mathematics, I remember they told me that like having 10 variables in a regression technique was like a lot. And I remember that was crazy. And now we're thinking about each of those lines represents a parameter in our model. And so our deep learning nets actually have upwards of thousands of parameters in which we are trying to optimize. And so it's really doing some fast computations. This is actually made very easy using linear algebra and some stuff that you can learn multivariable calculus. In the interest of time, I'm not going to talk about the mathematics of it, but if people are interested in, I love talking about that part, probably more than some of the other stuff. And I'm happy to kind of discuss the mathematics of optimization. So we have 3 major research efforts within our lab. First is imaging-based biomarkers using image analysis, using a deep learning platform to identify outcomes. The second is that we analyze audio data for patients in a collaboration with Amazon in order to model patient-reported outcomes. And the last is that we analyze clinical trial information to match clinicians to clinical trial using text data. Now, I think that the only reason I'm showing this slide is to kind of I guess highlight that it doesn't necessarily mean that just because image analysis is the most popular way in which people are using deep learning, that's the only way. I think there's so many different methods in which we can leverage this sort of technique across different types of heterogeneous data streams. The focus of today is going to be the imaging component, and specifically we're going to talk about 2 things. First is our early stage non-small cell lung cancer biomarker, and secondly we're going to talk about this new initiative that we have, which is called digital twinning. So imaging-based biomarkers. So a lot of the work here that I'm going to be presenting is actually being is because of an undergraduate named Justin Du and our former chief resident, who's now at Dana-Farber, Benjamin Kahn. And so a lot of the work that they've done is actually going to be presented here today. And a lot of the work that I did in my postdoc is on the image side. And so our thought is that cancer biomarkers have a number of problems. One, they're inaccurate. They potentially could be very expensive, require additional testing. They sometimes are invasive, and they're not necessarily personalized, and they maybe don't capture all the heterogeneity of a tumor. And so we created a deep learning platform which can essentially generate predicted personalized outcomes using pre-treatment diagnostic imaging. And we've shown that this to be effective in non-small cell lung cancer and as well in lymph nodes. And so this is just a schematic to kind of make it a little bit more clear. So tumor, there's pre-treatment imaging. The images are run through the platform, which is a lot more complex than this. And then we can develop a personalized outcome prediction. And the reason why it's so vague is because we really can predict multiple different outcomes from that network. And so what we have looked at is overall survival, local failure, distant failure, treatment-related side effects, and pathologic findings. And all of those can actually be looked at in the same model just by making multiple outputs. And so the first step was when we looked at early stage non-small cell lung cancer. So these are patients with small tumors, non-small cell lung cancer tumors that are treated with radiation therapy alone, stereotactic body radiation therapy. And so when we're thinking about it as a clinician, there's multiple variables that I think about whenever we're trying to predict outcomes for early stage non-small cell lung cancer. First, we're thinking about the images. What does the tumor look like? Then we're also thinking about the radiation therapy plan, which is basically, whether or not we're giving enough radiation dose to the tumor. And then we're also thinking about these clinical variables like, oh, how old is the patient? Do they smoke? Are they, do they have multiple comorbidities and things of that nature? And so when we're trying to kind of sort of parse out all those different types of data streams, if you will, it's very difficult for us to kind of, objectively do that. And we developed a model which allows us to kind of merge all those data streams through different types of neural networks in order to kind of create outcome predictions. We initially looked at just predicting overall survival, local failure, regional failure, and distant failure. And we compared it to individually looking at one data stream versus another data stream. And then we also compared it to what we consider to be a traditional model, which is like a Cox regression model. So basically predictions that would be generated from a Cox proportional hazard model. And so the important thing to appreciate from this figure is that the green represents the deep learning, the combined deep learning model. And we can see that it has an increased discriminatory value. And so this is an ROC curve. It essentially is a way for us to test how well our model actually orders samples based on their risk, but in the shortest way, it's a discriminatory measure. And what we also see is that it outperforms the Cox regression model, and it also outperforms each of those individual data streams alone. And so what we generate from this is that we should be, one, combining all of the available data that we have to us, and then secondly, that this deep learning algorithm is deep learning is a potentially useful way in which we can do that. And so just for those who are interested in a Kaplan-Meier curve based on our predictions of overall survival, what we can see is that if we look at the ones who were predicted to have death versus the ones who are not predicted to have death, and we track them out over years and years over time, in a more traditional Kaplan-Meier format, we see that there's a statistically significant difference in overall survival as well as disease-specific survival. Now, one big a drawback of deep learning models is this idea that there's so many parameters and they're not really kind of linked to coefficients like, variables like age and race and things like that. And so how do we know, what's the network looking at, and how do we know exactly what this model is doing? There's a lot of ways in which we can kind of fact check like regression-based models by looking at sort of, if the predictor makes sense. But I think that there's a big concern about the ability for us to interpret deep learning models. And so we've worked with some collaborators at the time who are at Georgia Tech, who are now acquired by Facebook, as a lab was acquired by Facebook. But they are looking at, they developed a technique called gradient-weighted class activation maps. What this essentially is doing is identifying areas of the pixel image at different layers of our network. And so what we can think about is that if it's highlighting, anatomically relevant areas, as it goes down the network, that means that it's looking at the places that a physician would look. So for example, if this model was looking at, if it was highlighting this patient's arm or their spine, then we know that we're just getting lucky that we were predicting correctly. But we can see when we're predicting local failure that we actually are looking as the network is learning and isolating the tumor. Now, the interesting part about this is actually, so this panel is a little bit complicated, but I'll explain it. So this is the original image. This is our local failure prediction. When we're looking at regional failure, this is the final prediction. And so when we are looking at regional failure, we see that the network is actually looking at the mediastinum, which to us makes sense that there's some relevance to that the model is actually looking at what we would look at as clinicians. This is the overall survival plot. I've heard different theories on it. I think some people think it's because it's looking at the heart and things of that nature, that it's potentially, that's what's highlighting, and then those organs are important. I think that actually what it probably means is that overall survival, not cancer-specific survival, so multifactorial, that really the picture is only a piece of the puzzle, but either way. And so now we've developed a collaboration with 4 other cancer centers, OHSU, University of Colorado, the University of Nebraska, and Jefferson, to externally validate this algorithm. Because one thing that we always worry about is whether or not this is actually generalizable across different patient populations. And so this is some of the work that Justin's been doing. So we have currently the Nebraska cohort and the Jefferson cohort. And what we see is in the Nebraska cohort that our combined model, it does not perform as well as our model here trained at Yale, but it still performs fairly well, and it still outperforms a Cox proportional hazard model. And I think the big thing about the regression techniques that's always been thought about is that they generalize quite well, meaning that they can work very well on unseen data. What we found is actually that the Cox proportional hazard model trained at Yale actually works significantly worse than if you compare the differences between the combined deep learning model and the external validation set. And that's actually been verified both in the Nebraska cohort and the Jefferson cohort. We've also started looking at side effects that are a little bit more rare, because we think this could be potentially useful in predicting something else that's a little bit more useful in the clinic at that moment. And so when we're looking at grade 3 pneumonitis, which is a common side effect that we worry about for radiation therapy, or grade 3 esophagitis, what we find is, again, that the deep learning model, which combines all the data streams, is actually particularly better than any of the other models, including a generalized linear model or our dosimetric parameters, which is in green, of what we actually have been taught to use as our cutoff clinically. Now, it doesn't only apply to lung tumors. We've actually seen that this is a very, very effective way in which we can evaluate lymph nodes as well. And so this is some work that was done by Benjamin Kahn, who was our former chief resident, who's now at Dana-Farber, which was essentially identifying lymph nodes that, one, have cancer, and secondly, have cancer that's spread outside of the lymph node. This is particularly important in the context of head and neck cancer patients, because it is a way in which we determine whether or not the patient needs chemotherapy or not. And so what he was able to determine first on an internally validated data set is that a deep learning model outperforms a logistic regression, as well as a more random forest model, which is another common machine learning technique. And secondly, when we did an external validation from patients at Mount Sinai Medical School, as well as in the Cancer Genome Atlas, the TCIA, the Cancer Imaging Archive, and we also compared it to radiologists, neuroradiologists trained here. One is that our model continues to have good performance, but also it is pretty much at the same level of the radiologist. The blue is actually very interesting. So the blue is actually indicating when we gave the radiologists the deep learning algorithm, whether or not their performance improved. And what we found is that one of the radiologists, his performance improved very well, and then one was slightly less. They didn't change a lot of their predictions, but I think that this is an area of ongoing interest, where whether or not we can kind of combine, human intelligence with the intelligence of machines to sort of improve prediction overall. So what are the future directions with respect to our non-small cell lung cancer? First and foremost, I think that we want to advance this in the locally advanced setting. And with our collaborators, we have kind of, developed a data sharing relationship, which has been very fruitful. This is just what we call a T-SNE plot, a T-stochastic neighbor embedding plot. It's a non-linear form of dimensionality reduction, a way for you to look at, it's a clustering algorithm of sorts of imaging features. And what we can see is that there's imaging features between partial responders and complete responders within stage 3 disease. And even within patients who have driver mutations, there's a complete response or a partial response, a complete versus partial response. There's some sort of imaging features. And so this tells us that the signal within the images should be able to help us identify which patients are responders and which ones are not. Secondly, we're interested in looking at our grad camps for recurrence prediction. And so this is a figure that highlights, this is a patient who had treatment, but the grad camp showed this area of a highlighted area that we didn't think was actually that important. And then a year later, we saw that that was actually where the tumor recurred. And so if we were able to theoretically look at this and appreciate that this was actually an area of risk, then we could have potentially done something different, potentially treated this little spot here, which actually, I guess, turned out to be cancer. And the last thing is we want to integrate PET-CT into the model, just because what we've been noticing is that PET actually has a very, very good indicator. Deep learning analysis of PET images sort of gives us a good signal. So we can see the PET imaging of this patient who survived for a very long time. The PET imaging is very, very crisp, and this one's a lot more erratic. And that sort of erraticism, that sort of erratic PET signal on the deep learning model suggests that potentially they have a lower life expectancy. Okay, so in the last 5 minutes, I'm going to talk about this ongoing project, which is pretty interesting. Partially because two of the strongest undergrads I've ever met in my entire life are working on this. Gabriel Sarushi and Amar Gupta, who are working on this idea of digital twins. And so basically the idea is that can we leverage deep learning to identify patients who are previously looking similar to us? And how do digital twins actually, how do their outcomes differ from ours? And so similarly, we employed our deep learning platform with the techniques that are oftentimes used for facial recognition software to find patients that are similar. And so we have two things. One is digital twins, which is the best match among our cohort. And second is a digital family, which is a kind of an average of the 10 similar to you. And so this is just a schematic. Similarly, we take the pre-treatment images, we identify the digital twin using an algorithm that I'll show you in a little bit, and then we kind of see how their outcomes look. And so this is the idea of a digital twins. We take three of our deep learning models, and we have the parameters are shared between the three, but we actually have to minimize the distance between the similar images. So the vectors that are created from the similar ones, they need to be close together, and the ones that are very different have to be very far apart. And so there's an anchor image, which is basically an image that's true. This is what you want to look at. That's our cancer patients. There's a positive image, which is that image, and it's in a different orientation. And so what we oftentimes have been doing is looking at them on a different scan that they've had, or an alternative slice. So it's kind of a different perspective of that image. And then there's a negative image, which is basically an image that is the wrong one. It's a different image. So I'll tell you, I changed the slide because it's a little too politically charged. Yes, these undergrads, you got to be careful. And so the negative image is a wrong and different image. And so what we use for the wrong images were normal lung, and then non-cancer findings, and then not benign nodules. And so we did it in a trained format to make sure that it was learning the easy stuff first and then the hard stuff later on. And then I think it's just important to understand what the objective function is in this one, because I think that's where the true innovation is. What we were trying to do is, so this is your, so this is a loss function. This is the function that you're trying to optimize, which is taking your actual image, your positive image, and your negative image. And you want to maximize, you want to minimize the distances that exist between your actual image and the positive image. And you want to maximize the distances between your negative image and your image, right? And so I think it's important to look at sort of whether or not they actually look like twins, like are they looking the same? And what we found is actually they do not. Oftentimes their gender is different than what their digital twin is. Their race is oftentimes different. The things that did seem to be kind of sort of correlated were histology and driver mutations, as well as age. It's something that we're going to continue to look at, but interesting nonetheless. So I wish I could show you guys the photos of the people just to kind of show you how different some of these digital twins look compared to some of their, I guess their siblings. But it's pretty stark, and I think it kind of helps us understand that potentially there's something else underlying that. And so what we did is we actually took the digital twin and the digital family. We looked at their overall survival estimate based off of the average of those ones. And then we subtract that to the actual estimate, so the actual overall survival. And so what you can appreciate from this, and we compared it to what would be predicted from a matching algorithm, stage, or a Cox proportional hazard algorithm. And so what we can see is on the right is when we would underestimate potentially how much their survival would be. And then the left is that we would overestimate. So we basically be too optimistic. And what we found is that the digital twins, especially the digital family, is actually associated with a very, very good actual estimate of your prognosis versus the stage, which is actually pretty erratic. And I think that we have like a wide variation in terms of how we're predicting patients, which is typically what we would kind of look at. I know that in my clinical practice, that's pretty much what I would kind of look at as the statistic that I would mention to people. And they tend to be actually sort of underestimating the survival of the actual patients. I think it's also important to note that the matching algorithms, which are based off of Euclidean distance, and it's more based off of demographic features, are also somewhat effective. Great. Just to close, deep learning methods appear to have utility in diagnostic image analysis. Deep learning models represent a unique way for us to merge multiple streams of data. And we continue to do external validation just to make sure that we can appreciate that these are prognostic, even on data sets that were not used here at Yale. And I just want to take a moment to thank all the members of my lab, the Department of Therapeutic Radiology and the Department of Statistics and Data Science, and as well the Center for Outcomes Research and Evaluation, where I did my postdoc. And you guys can follow us on our GitHub. We have all the code available for you guys.
Some questions. That was a great talk. Well, I'll start. You walked in a little bit into one of the general questions that's come up with these approaches, is the difficulty
in knowing what's going on in that black box. And I know people are developing forensic methods basically for going back in, and you talked about some of those. What are the long-term prospects of really being able to get a handle on what these algorithms are doing?
In the context of image analysis, I think that we're pretty close. I think that so the gradient weighted class activation maps, I think, are very, very effective. I think that but the most important thing is that I don't know if we can necessarily take the next step where we can actually look at an image, see what parts of the image are important, and then know that that is correlated with some sort of biological next step for translation. I think the more complicated piece is unpacking the black box for non-imaging data. So for the audio study that we're doing, it's very difficult for us to sort of unpack why certain things are getting predicted one way versus another. And I think that's going to be more difficult. The images are nice because you can kind of look at what parts of the pixel, what pixels were most important in generating an output. And so I think that it's more difficult for the non-imaging sort of data.
Okay, I've got another question. So recently in the New York Times, there was an article about the potential development of a have and have not situation in which only a few centralized industrial groups, A, had the collections of data sets, and B, had the computational power to really push the ball forward on machine learning.
Yeah, no, that's true. I think that's the reason why a lot of the groups don't necessarily want, or not necessarily don't want them to, but they're not really necessarily invested in academic groups. If you have a deep learning model that's very basic, if you have the most data, it'll still model correctly. And so I think that's why it's important for us to sort of, our group spends a lot of time investigating different unique methods in which we can kind of compress data streams to make them smaller. I don't feel like computationally we're particularly behind compared to other groups. I mean, especially Yale specifically, we have basically the two top of the line computers, and they're relatively available for everybody. Just in case everyone's interested. I don't feel necessarily that's going to be the issue. I think the bigger issue is that whoever gets control of the data is going to be the ones who are going to be the leaders of the pack. And I think it's actually not going to be necessarily an industrial group. I think it's more of other international groups that have open access. So we have a collaboration with the municipal department of Shenzhen, China, and they have a complete electronic medical record. And in order to get care there, you have to provide your data for their data group. And so like the ability for them to have an electronic medical record, they have like almost thousands upon thousands of images every day that are uploaded. It's pretty impressive. And so I think that's the more worry that we would have. It's not necessarily that industrial groups, but more other governments that are maybe less regulated about data control.
Any questions from the audience? Can you shout it out? How many patients?
Good question. So for the early stage non-small cell lung cancer patients, we traded on 500, but we use data augmentation with bootstrapping to make it about a 5,000 patient sample.
What about for the other
You mean for the? Yeah. So the external validations for each of those is 200 patients. Yeah. So those are completely blind tested. No parameters are changed. They're not trained at all on that. It's just a test set.
Okay, well, one last question from me. Do you have any way of knowing from the structure of the data set you're working with what scale of data set size you'll need to do the analysis you're trying to do within the design?
Good question.
Accuracy?
So there's no way to calculate like power that you would need for it. I think that a lot of times people do learning curve analysis. That's what we do in our group. And so you take batches of training data, smaller batches of training data, and you see whether or not your error function optimizes on smaller sets. And then you can kind of increase that over time. As long as the curve is asymptoted, then you know that you're at the right number. For CT scans,